I think, one of the questions that torments urologists, and I think we really value the input of the medical oncologist, is how we approach perioperative systemic therapy in patients with upper tract disease. I think, there's strong theoretic benefit for a neoadjuvant approach, but we have level 1 data for the adjuvant approach from POUT. And so I'm interested in your thoughts as a medical oncologist about how you approach these clinical decisions.
Thank you so much, Chris. These are great questions, very important questions. And I think there is a continuous debate that is happening in the field regarding the role of neoadjuvant or adjuvant chemotherapy for patients with upper tract urothelial carcinoma. Let me just starting by saying that, in contrast to bladder cancer, we have less definitive data with upper tract urothelial cancer in terms of definitive evidence for phase 3 trials. And this is because it's less common disease, lower frequency, and that leads to higher difficulty in accruing and completing definitive phase 3 trials in upper tract disease. Having said that, I think it's very important to complete those trials, to pursue and complete those trials in dedicated upper tract trials in patients with localized, not metastatic upper tract urothelial cancer. In that context, I think there's a debate ongoing right now regarding the value and role of neoadjuvant or adjuvant chemotherapy in patients with localized disease. Obviously, we have data from the POUT phase 3 trial in UK, published by Dr. Biddle and her team, that looked at patients who had high risk of recurrence urothelial carcinoma, who had PT2 or higher states, pathologic states and high risk of recurrence, and those were randomized to adjuvant GEM-CIS or active surveillance, and a small proportion of patients got adjuvant carbo-GEM. Obviously, this trial was not powered fully for overall survival, but showed significant disease-free survival benefits with adjuvant gemcitabine cisplatin in this particular context. The subset of patients with adjuvant carbo-GEM was much smaller, and I think the data with adjuvant carbo-GEM is probably not definitive, and there is a significant challenge in the clinic, right? How we take care of these patients, how we make decisions. Having said that, I think in my mind, the evidence is clear in patients who never received neoadjuvant chemo and they come to me after an radical nephroureterectomy. The data support adjuvant GEM-CIS if some patient has a T2 pathologic T2 or higher states or not positive disease. There is a longer dialogue about pros and cons and underpowered subset of patients who got carbo-GEM adjuvantly. I think the other relevant point here is that many patients may not be able to receive adjuvant cisplatin-based chemotherapy because of the loss of kidney function and the low GFR. And that's why they allowed this subset to get carbo-GEM at the POUT trial. And again, a small portion got carbo-GEM, about 96 patients. Now, because of that, there is significant effort, and I agree with that effort, to consider upper tract neoadjuvant trials in this setting. And there have been a number of trials looking at this, mostly phase 2. And one of them is the ECOG-ACRIN 8141 that was published by Dr. Margulis and Dr. Hoffman-Sensic. This trial accrued about 29 patients with upper tract disease, localized, and had a pathologic complete response rate about 14%, 14%, with dose-dense MVAC as neoadjuvant therapy. There was a similar trial in New York by Dr. Coleman, Dr. Heap, and colleagues looking at GEM-CIS, gemcitabine cisplatin, as a neoadjuvant therapy, and that showed a pathologic complete response rate 19%. So the PCR rate is between 14 and 19% in those small trials. But however, we also have retrospective data we published with Dr. Almasi and myself and others looking at the pathologic downstaging in patients who receive neoadjuvant chemotherapy. This downstaging is much higher rate of downstaging, pathologic downstaging, in patients who receive neoadjuvant chemotherapy versus those who did not receive that. And pathologic downstaging seems to have an association with long-term outcomes. Disease-free survival. Obviously, this was a retrospective study with all the caveats, but putting everything together, I am an advocate of considering neoadjuvant cisplatin-based chemotherapy in patients with high-grade upper tract urothelial cancer. It's extremely difficult to prove muscle-invasive disease. There is significant risk of understaging, which I think makes things more complicated. But if there is a high concern, clinical concern, let's say, for high-grade invasive disease, even if you cannot prove it histologically, I'm an advocate of considering neoadjuvant cisplatin-based chemotherapy, either with Dosdensenvac or GemCis in fit patients who can safely receive either of those two cisplatin-based regimens. And to end that long discussion point, there is an important phase 3 trial right now called the ECOG-ACRIN 8192. This is a phase 3 trial looking at Dosdensenvac with or without durvalumab, an anti-PD-L1, in cisplatin-fit patients neoadjuvantly. They're getting up 4 cycles of Dosdensenvac with or without durvalumab. And there is another cohort, separate cohort, with gemcitabine, durvalumab, this combination for cisplatin ineligible patients. There are 29 patients who cannot get cisplatin, and they get gemcitabine durvalumab. So I think this trial will be very important. ECOG-ACRIN 8192. I hope colleagues across the country can open that trial. It's vital in order to get answers for the neoadjuvant therapy of upper tract urothelial carcinoma.
So we know based on checkpoint 274 that there's a role for the adjuvant nivolumab for patients who have received that neoadjuvant chemo. And I'm wondering your thoughts on the data looking maybe a little bit here in the subgroup analyses of the effect in the upper tract patients as compared to those with bladder cancer.
Yeah, it's a great question, and thank you for asking this. So, like every phase 3 clinical trial, CheckMate 274 trial tried to answer the question of adjuvant nivolumab versus placebo in patients with high risk of recurrence after fully resected urothelial carcinoma of bladder or upper tract. The challenge was that that only a small minority of patients had upper tract disease in this trial, CheckMate 274. So the trial was completely underpowered to answer the question for upper tract. And if we look at the forest plot, I always remind myself and trainees that we cannot overinterpret underpowered forest plots that are not destined to answer the question definitively. And if you think about the low number of patients with upper tract and also the low number of events, right, a recurrence or death in those patients, I think it's almost impossible to draw any definitive conclusions for adjuvant nivolumab in this subset, which means this is an option for the patients. We discuss it. I think the take-home point is you have a patient who comes to me in clinic. This patient is not eligible for cisplatin, could not get neoadjuvant chemo. That will be, I would consider him for the clinical trial if I knew before the surgery. Cohort A or B cisplatin fit patients, cohort cisplatin fit patients. They go 8192. If they come to me after, and I never had the chance to think about that trial, and they come to me in the adjuvant setting, and they're chemotherapy naive. If they have PT2 or higher stage, and they're fit for cisplatin, I consider adjuvant GemCis up to 4 cycles. If they are not fit for cisplatin, again chemotherapy naive, cisplatin ineligible patients, ideally a clinical trial will be ideal. In the absence of a trial, that's a very long discussion because we have 3 options, right? Adjuvant carbogem, and again, underpowered subset of POUT. However, in that underpowered subset of POUT, there was a trend towards disease-free survival with adjuvant carbogem versus surveillance. So, and some people think it's just a power issue. So it's an option for those patients. We discuss pros and cons, again, the uncertainty regarding the statistical rigor of this power, the power subset of carbogem, but it's an option, and even higher degree of uncertainty with adjuvant nivolumab. And I think that illustrates why we need dedicated upper tract trials to answer the question definitively, and versus active surveillance in those patients. I think it's something that we discuss with the patient, pros and cons, and informed and shared decision making.